So now we're going to turn our attention to an issue that we raised a little while ago when we talked about the fact that the ventral mesentery will mostly disappear. So when we look at the general pattern of the embryonic abdomen, we see what we've been talking about up until now, a gut tube with a dorsal mesentery and a ventral mesentery, and the aorta is in the dorsal body wall, and the blood supply to the gut tube is getting to the gut tube through the dorsal mesentery. And then we said that for most of the length of the gut tube, certainly once we get beyond the second part of the duodenum, the ventral portion, the ventral mesentery, is going to disappear. So this diagram would get converted from this appearance to this appearance, where we no longer have a ventral mesentery. So we've had a loss of the ventral mesentery. As a result of that loss, there are two important things that have happened. One is that instead of having two peritoneal cavities, a right and a left peritoneal cavity, we now have one peritoneal cavity. They are continuous because we no longer have that dividing boundary of the ventral mesentery. So that's one major result of that. The other important result is that because we no longer have two mesenteries tethering the gut tube to the body wall, before we lost the ventral mesentery, we had a dorsal mesentery tethering the gut tube to the dorsal wall and a ventral mesentery tethering it to the ventral wall, which means you couldn't move the gut tube. But now that we only have one mesentery, because we've lost the ventral mesentery, we've now given the gut tube mobility. The gut tube can, in fact, swing back and forth, being pivoted around that single point of attachment. So the loss of the ventral mesentery gives the gut tube mobility that it did not have before. Now, one might ask the question, if losing a mesentery is a good thing to allow the gut tube to have mobility, why is it always the ventral mesentery that we lose? Why not keep the ventral mesentery and get rid of the dorsal mesentery? That would also give us mobility. But this diagram gives us the answer because we can see that the aorta is on the dorsal side. So the blood supply to the gut tube must be coming to the gut tube from the dorsal side. Therefore, we need the dorsal mesentery as a pathway for the blood supply to the gut tube. So we retain all of the dorsal mesentery, but we lose most of the ventral mesentery. But that could lead to another good question, which is, why do we keep some of the ventral mesentery? Why don't we get rid of all of it? What was the point of keeping some of the ventral mesentery? And the answer to that is based on the same notion that mesenteries serve as a bridge to allow blood supply. So indeed, in the embryo, there is a blood vessel that comes in from the ventral side that is needed, and that, of course, is the umbilical vein. The umbilical vein comes from the ventral side. When it reaches the embryo's ventral body wall, it needs a pathway to continue on into the embryo, and so it needs a ventral mesentery. So when we look at the adult, it's not a surprise that when we look at the adult remnant of the ventral mesentery, remember one of those remnants is the falciform ligament. This was ventral mesentery. And if we look at the place where that ventral mesentery suddenly ends, so here we have it, and then we said the rest of it is gone. So there's a free edge. Well, the place where that free edge is, in other words, the very last bit of ventral mesentery that we retained, was retained because that's exactly where the umbilical vein was coming in. And in the adult, the remnant, the fibrous remnant of that umbilical vein is now called the ligamentum teres. And so it's not a surprise that we're going to find the ligamentum teres, the adult remnant of the umbilical vein, in the free edge of the falciform ligament, because the falciform ligament is the adult remnant of the ventral mesentery. Once we get caudal to where the umbilical vein came in, we no longer need a ventral mesentery because nothing else is going to come from the ventral side, and so all of the rest of the ventral mesentery is lost. And that's why in the adult, the two mesenteries that are ventral mesentery remnants, the falciform ligament and the lesser omentum, both have free edges. There's the free edge of the falciform ligament. That's the free edge of the lesser omentum. That's where the ventral mesentery suddenly ends. From there on, it disappeared. Okay, so let's come back to our gut tube that now doesn't have a ventral mesentery. We said it therefore now has mobility. It can swing from side to side. And so let's take advantage of that mobility and move the gut tube from this position over to this side. We'll just move it over here to the embryo's left side. And all we're going to be doing is taking the gut tube, move it from here to there. The dorsal mesentery will, of course, come with it. The blood supply to the gut tube, which is in the dorsal mesentery, will also come with it. So that's all that's going to change from this slide to the next, is all of this will get pushed over to that side. There it is. So there's the dorsal mesentery, there's the blood supply to the gut tube, still getting to the gut tube through that dorsal mesentery. But as a result of being moved over like that, notice that that surface of the peritoneum, in other words, that surface of the dorsal mesentery, and in fact that surface of the visceral peritoneum, comes into very close proximity with that surface of the peritoneum, in other words, the parietal peritoneum. Those two peritoneal surfaces are very close together, and we can certainly imagine that if we just move them just a little bit more, those surfaces would come into contact. And that indeed is what's going to happen. Those peritoneal surfaces will come into contact. Now, when you look at a peritoneal surface, any peritoneal surface, what you find is that what's covering the surface of the peritoneum, the surface that's facing the peritoneal cavity, is a layer of epithelium. A layer of epithelium covers the peritoneal surface there, and of course covers the peritoneal surface there. So when those peritoneal surfaces come into contact, that means we're bringing epithelium up against epithelium. Now, when that happens at the right time during development, and if those surfaces remain in contact for the right length of time during development, what will happen is the epithelial cells that are in contact with one another will die. And as a result of the loss of those epithelial cells, we'll now have the connective tissue that was sort of serving as the backing for the epithelium. Without the epithelium there, we'll now have connective tissue in contact with connective tissue, which will allow for those fibers of the connective tissue to interweave and thereby fuse together. So what we're saying is we'll lose epithelium, those surfaces will come together and will fuse like that. And so what we're saying is that with the loss of epithelium, because we said that a peritoneal surface has an epithelium, and since this now no longer does have an epithelium, this no longer can be called peritoneum, where the fusion occurred. That's no longer peritoneum because it doesn't have an epithelium. What we call it now is simply fascia, fusion fascia. Well, now that this is no longer being called peritoneum, when we look at this piece of gut tube and ask the question, is it completely surrounded by peritoneum? Now the answer is no. It was completely surrounded by peritoneum when this used to be called peritoneum, but now that this is not peritoneum, now we have to say that this piece of gut tube is partially covered by peritoneum, but not completely surrounded. And if it's partially covered by peritoneum, but not completely surrounded, the name that we give to that kind of an organ is a retroperitoneal organ. Now, a moment ago, before we just did that, we were saying that this organ was called a peritoneal organ because it used to be completely surrounded by peritoneum. And now we're calling it a retroperitoneal organ. And the nomenclature we use to indicate that is we call this a secondary retroperitoneal organ. A secondary retroperitoneal organ. That implies that it used to be peritoneal, but now secondarily, it's now a retroperitoneal organ. And that way we can contrast that kind of a retroperitoneal organ with an organ such as the kidney, which has been retroperitoneal all along. So we call that kind of a retroperitoneal organ a primary retroperitoneal organ. Okay, so primary retroperitoneal organs, such as the kidney, such as the aorta, are organs that start off retroperitoneal and stay retroperitoneal. Secondary retroperitoneal organs are organs that start off peritoneal, or if you like, intraperitoneal, and then as a result of the process we just looked at, they become secondarily retroperitoneal. Now, let's continue following the rules. We're now calling this retroperitoneal because the rules say that's what you have to call it if it's not completely surrounded. Well, the second rule was, now that this is retroperitoneal, the peritoneum that's covering it has to be called parietal peritoneum. So we're going to call that parietal peritoneum. That's the very same peritoneum that a few moments ago we were calling visceral peritoneum. The peritoneum hasn't changed. Its relationship to the organ hasn't changed. But because we changed what we call the organ, we have to change what we call the peritoneum. So recognize that this process that we're describing, this process called secondary retroperitonealization, is not some mysterious process where organs move from one side of the peritoneum to the other. The organs basically stay where they are. The only thing that has really changed is that some epithelial cells here died. And as a result of the death of those epithelial cells, we can't call that peritoneum. If we can't call that peritoneum, we now have to call that a retroperitoneal organ. If I call that a retroperitoneal organ, I now have to call that parietal peritoneum. So it's basically a cascade or a sequence of name changes in order to comply with the rules of nomenclature that we have. Well, let's take that one step further. Recall that the definition of mesentery was a peritoneum that connected parietal peritoneum to visceral peritoneum, and we were calling this dorsal mesentery. And it was okay to call this dorsal mesentery when we were calling this visceral peritoneum, because then it was connecting parietal to visceral peritoneum. But now that we've changed the name of this to parietal peritoneum, now this is connecting parietal to parietal. So we can't call that mesentery anymore, so we call that parietal peritoneum. And of course this was always parietal peritoneum, so we still call it parietal peritoneum. So what this says to us is that when we open up the peritoneal cavity in the adult and we look at the parietal peritoneum that's surrounding that cavity, we now can see that some of what we're calling parietal peritoneum was always parietal peritoneum. Some of it used to be mesentery but has changed its name to parietal peritoneum, and some of it used to be visceral peritoneum but has changed its name to parietal peritoneum, all as a result of following the rules of nomenclature subsequent to the fusion here and the death of those epithelial cells. Well, we can take this one step further. This blood vessel that's supplying this gut tube, we used to say it was in the dorsal mesentery, and it had peritoneum on both surfaces. Well, now it doesn't have peritoneum on both surfaces because that's not peritoneum, so it only has peritoneum on one surface. It's behind that parietal peritoneum, so we would say that that blood vessel is secondarily retroperitoneal. Not only is this gut tube in this region secondarily retroperitoneal, but its blood supply is now secondarily retroperitoneal. And we can in fact generalize that concept to say that any organ that is a secondary retroperitoneal organ is an organ whose blood supply will be secondarily retroperitoneal. And similarly, any organ that is a primary retroperitoneal organ will have a blood supply that is primarily retroperitoneal. So here's an interesting thought for us to ponder on. Why is this something we want to know? What's the value of knowing this other than just for the academic interest in embryology? And what this does for us is give us a model for understanding spatial relationships in the abdomen. When we look at this schematic diagram, we can point to 4 different organs or structures that are retroperitoneal in the adult. This piece of gut tube is retroperitoneal. Its blood supply is retroperitoneal. The kidney is retroperitoneal. And the aorta is retroperitoneal. But even though all 4 of those structures are retroperitoneal and all 4 of them are behind the parietal peritoneum, which is where you'd expect a retroperitoneal organ to be, we can see that they're not really all in the same plane. We can see that the two structures that are secondarily retroperitoneal, in this case the gut tube and its blood supply, are in front of the two structures that are primarily retroperitoneal, and that there's a layer of fascia separating them in the retroperitoneal space. And so indeed, if we generalize this to all of the retroperitoneal structures in the abdomen, we can say that we should always anticipate that a secondary retroperitoneal organ will be in front of a primary retroperitoneal organ. It has to be that way, and if we look at this schematic of how secondary retroperitonealization occurred, we can see that it has to be that way. So if we can just know which organs are which, that will avoid the need of learning literally dozens of separate spatial relationships, because if we can just categorize the organ, we will know what will be in front of what. So if we look at this chart, we see the major organs of the abdomen put into three categories. The organs that are peritoneal or intraperitoneal in the adult. That means the organs that start off peritoneal and remain peritoneal. In other words, the organs to which the process we just described did not occur. So the stomach and the spleen and part of the duodenum and much of the small intestine and so forth, transverse colon, sigmoid colon, those are organs that start off peritoneal and remain peritoneal. The organs to which the process that we just described happen are these organs. Most of the duodenum, most of the pancreas, the ascending colon, the descending colon, and the upper part of the rectum. Those are the organs that become secondarily retroperitoneal. There aren't that many of them, as we see. And then we have this whole bunch of organs that start off retroperitoneal and stay retroperitoneal, just like the kidneys that we saw in the diagram, similarly the adrenals and the ureter and the aorta, vena cava, the lower part of the rectum, and the anal canal. These are all the primary retroperitoneal organs. And then if we add that concept that we just talked about, that the blood supply to an organ will be in the same category as the organ itself, we can say that all of these organs and their blood supply are primarily retroperitoneal. All of these organs and their blood supply are secondarily retroperitoneal. And all of these organs that are peritoneal have their blood supply reaching them through a mesentery, since all peritoneal organs get their blood supply through a mesentery. So based upon that, we now know that, for example, the blood supply to the descending colon, which is the left colic artery, is going to cross in front of the ureter. They both go across the posterior abdominal wall. They cross one another, but this tells us that the left colic artery has to be in front of the ureter, not the other way around, because this is secondarily retroperitoneal, this is primarily retroperitoneal. That's just one example. There are many such examples, and as long as we know which category the organ belongs in, we don't have to separately memorize each relationship. So now we turn to the last major embryonic topic that helps explain adult structure of the GI tract, and that is the rotations of the gut. The rotations of the gut. And that's written as a plural because there are, in fact, two separate rotations. They occur at different times, they occur in different parts of the gut tube, and they occur in different directions. And so we'll talk about them one at a time. The first rotation, the rotation that occurs first, is a rotation of the foregut. It's a rotation of the foregut. And that rotation is going to be a rotation that is around the axis of the gut tube itself. The long axis of the gut tube is the axis of rotation for this foregut rotation. And it is a 90-degree rotation, such that the ventral side goes to the right and the dorsal side goes to the left. To understand what that means, let's take a look at a model. Let's imagine that this tube of paper is the foregut. What we're saying is that it's going to rotate around its own long axis. In other words, my finger, being the long axis of the gut tube, is the axis around which it's going to rotate. And I said it will rotate 90 degrees so that ventral goes to the right and dorsal goes to the left. So I'm going to put my right hand on the ventral side of the gut tube. I'm going to put my left hand on the dorsal side of the gut tube. Then when this rotates 90 degrees, ventral goes to the right, dorsal goes to the left, just like that. That's all there is to it. 90 degrees, ventral to the right, dorsal to the left. That simple rotation now explains to us why the liver, which formed in the ventral mesentery in front of the gut tube, as a result of that rotation, the liver ends up on the right. The spleen, which formed in the dorsal mesentery of the stomach, behind this gut tube, as a result of that rotation, the spleen is now on the left. So the liver is on the right and the spleen is on the left because of that 90-degree rotation. Well, that 90-degree rotation of the foregut has several truly profound effects on the spatial orientation of structures in the upper part of the abdomen. The next slide shows us a cross-section through the foregut region before rotation. And largely this is familiar. We've already seen much of what's on this slide. This is the stomach. We know that there's a dorsal mesentery of the stomach, and we know that a spleen develops in that dorsal mesentery. And when the spleen develops, we rename that into visceral peritoneum of the spleen, and then we rename that gastrosplenic ligament. We rename that splenorenal ligament. Remember, that's the mesentery whose name didn't make sense. We have the splenic artery passing to the spleen through that splenorenal ligament. That's all old news. And then on the ventral side of the gut tube, we have a ventral mesentery. We said that the ventral mesentery that's attached to the gut tube is going to be called the lesser omentum. So that will be the lesser omentum. Now, this diagram is somewhat different from the one that we looked at earlier because we've drawn it so that we're cut through a part of the ventral mesentery where it ends. We said it persists for a while and then it ends, so there's going to be a free edge. So we've cut it through its free edge. So we're out of the plane of where the liver develops in the ventral mesentery. We're a little bit below that plane. Okay, so that's the ventral mesentery or the lesser omentum. There's the free edge of the lesser omentum. We said that this foregut is going to rotate around its own long axis. So there's the axis of rotation. And we said it would rotate so that dorsal goes to the right and dorsal goes to the left and ventral goes to the right. So it'll rotate in that direction 90 degrees. Now recognize that in order for that to happen, in order for the spleen to end up over here, this mesentery, this splenorenal ligament with its contained splenic artery has to get much longer to allow the spleen to move over to here. So indeed, this mesentery will get much longer with its contained artery. That will allow the spleen to go here. That means the ventral mesentery or the lesser omentum, which is now pointing ventrally, when it moves will be pointing to the right. So let's take a look at that next picture. And we've left the original picture up in the corner here just for comparison purposes. So there's that lesser omentum, which was pointing ventrally. It's now pointing to the right. There's that gastrosplenic ligament, which was heading off dorsally. It's now heading off to the left. And there's that splenorenal ligament that was fairly short and went from the spleen to the dorsal midline. It's now quite long. It still goes to the dorsal midline, but it had to get longer to allow the spleen to move over to the left. So that's the result of the rotation. And as a result of that, we can see that we've taken some of the peritoneal cavity that was on the right side of the abdomen, and we've tucked it in behind the stomach. And we call that part of the peritoneal cavity the lesser sac, or the omental bursa. And then all of the remainder of the peritoneal cavity is going to be called the greater sac. And we can see that the pathway to get from the greater sac to the lesser sac is to pass around the free edge of the lesser omentum. By passing around the free edge of the lesser omentum, we can get from the greater sac into the lesser sac and pass through that little gap between the free edge of the lesser omentum and the posterior abdominal wall. And so that space there, between there and there, has been given the name epiploic foramen or foramen of Winslow. That's the pathway into the lesser sac that was created by this 90-degree rotation. So you should anticipate now that if you were to pass your finger in the adult abdomen, if you were to pass your finger through the epiploic foramen, you would first pass behind the lesser omentum, you would then pass behind the stomach, you'd then pass behind the gastrosplenic ligament, and then you'd hit the spleen, and that would be a dead end. That's as far as you can go, and that indeed is the case. Okay, and we'll take a look at that in the adult in a few minutes. Now, recall that in the free edge of the lesser omentum is where we said we would find the bile duct. So right about there is where we should find the bile duct. And not only is the bile duct there, but accompanying the bile duct is going to be the hepatic artery and the portal vein. Those three structures, called the portal triad, portal vein, hepatic artery, and common bile duct, sit together in the free edge of the lesser omentum. So that means that if you were to stick, let's say, your index finger into the epiploic foramen, leaving your thumb outside on the front of the lesser omentum, and squeeze between your thumb and index finger the free edge of the lesser omentum, what you'd be squeezing between your fingers is the hepatic artery and the portal vein, which means the entire blood flow into the liver is right there between your fingers. And so if you have to stop blood flow to the liver because of, let us say, for example, a lacerated liver, that's where you can localize all of the blood flow into the liver. It also shows you that in the adult you'd expect that the posterior wall of the stomach is facing the lesser sac, while the anterior wall of the stomach faces the greater sac. And that turns out to be important because sometimes stomach walls perforate as a result of trauma or ulcers or tumors. And so if you perforate the stomach wall, the gastric content, which is quite acidic, of course, because of the hydrochloric acid produced in the gastric mucosa, that acidic gastric content will spill out of the stomach into the peritoneal cavity. And that means that a posterior wall perforation will spill into the lesser sac, an anterior wall perforation will spill into the greater sac. And as a result of being in two different parts of the peritoneal cavity, they can spread into different regions of the peritoneal cavity, presenting two very different clinical presentations in terms of the localization of the pain. This also shows you that if you wanted to gain surgical access into the lesser sac, in the left part of the lesser sac, you can go through the gastrosplenic ligament. You can incise the gastrosplenic ligament, separate the spleen from the stomach, and give you a wide opening into the lesser sac. However, notice that even though the splenorenal ligament separates the greater sac from the lesser sac, that's not something you can perforate or incise to get from the greater sac to the lesser sac, because the splenic artery and splenic vein and, in fact, the tail of the pancreas are all in there, so you can't cut through that. On the right side of the lesser sac, you can see that you can get from the greater sac to the lesser sac by incising the lesser omentum. But just to be more precise, notice that if you can incise the lesser omentum, but you cannot incise the region of the lesser omentum near its free edge, because that's where the portal triad is located. But you can incise this much larger part of the lesser omentum, the part closer to the stomach. And we'll take a look at that on an illustration in a moment. Okay? The last point to be made is that as a result of this rotation and the spleen and its mesentery being swung over to the left side, we can see that this peritoneal surface is brought very close to this peritoneal surface. In other words, the dorsal mesentery of the spleen, or more specifically the splenorenal ligament, is being brought right up against the parietal peritoneum. And as we said before, when that happens, when those surfaces touch, the epithelial cells will die, resulting in a fusion with connective tissue in between, and so we'll end up with a fusion like that. But notice that the very last part of that mesentery, the part closest to the spleen, is not up against the parietal peritoneum, so that part doesn't fuse. So most of that mesentery fuses, the most ventral part of it doesn't fuse, or the most distal part of it doesn't fuse. So when you look at this in the adult, it looks like this mesentery is attached to the dorsal body wall in the region of the left kidney. That kidney should be over there, in the region of the left kidney, and that's why it has the name splenorenal ligament. Even though we know that it's actually going back to the dorsal midline, because of that fusion there, it looks like it's attached over here. Okay, so let's see how this relates to the adult. Now, in this cross-section of the adult, instead of having the orientation that's conventional for the embryonic cross-section, we have the orientation that's conventional for CT scanning of the adult. So ventral is now over here, and dorsal is over here. This is right, and this is left. So now we see, here's the stomach, there's that ventral mesentery pointing off to the right. So that's the lesser omentum. There we see the dorsal mesentery of the stomach heading over to the spleen, so that's the gastrosplenic ligament, and then that's the continuation of that mesentery, that's the splenorenal ligament. See the lesser sac, or the lesser peritoneal sac, or the omental bursa. All of this out here is the greater sac, and we can see that the pathway from the greater sac into the lesser sac is, in fact, around the free edge of the lesser omentum through this gap that's called the epiploic foramen. We said we should anticipate that when we enter the epiploic foramen, we would first pass behind the lesser omentum, then we'd pass behind the stomach, then we'd pass behind the gastrosplenic ligament, and we'd hit a dead end at the spleen. And that's indeed what we have. We said that we should anticipate that the lesser omentum separates lesser sac from greater sac, and that while you can incise this part of the lesser omentum, the part that's actually called the hepatogastric ligament, you cannot incise this part of the lesser omentum, the part that's called the hepatoduodenal ligament, because of the presence of the portal triad within that part near the free edge of the lesser omentum. Okay, you can incise the gastrosplenic ligament, but remember you cannot incise the splenorenal ligament because the splenic artery is going to be passing through there. Okay. Now, the other rotation is a rotation of the midgut. Now, the rotation of the midgut is a rotation that occurs a little bit later. Obviously, it occurs in the midgut portion of the gut tube. And its axis of rotation is not the long axis of the gut tube, but rather the axis is the superior mesenteric artery. We'll take a look at an illustration to see what that means in just a moment. And that rotation will be 270 degrees of rotation in a direction that would be called counterclockwise if you're viewing it from the ventral side of the embryo. So it's a 270 degree rotation, counterclockwise viewed from the ventral side. Contrast that with the 90 degree rotation of the foregut, and it's around the axis of the superior mesenteric artery, not the long axis of the gut tube. So an entirely different rotation in a different direction in a different part of the gut tube. If we look at the gut tube and look at the region that we called midgut, we can see that that part of the midgut has gotten very long, very long. And it's gotten so long that it actually was not able to stay in the abdominal cavity. So this is what's happening here. The midgut is the part of the gut tube that must become very long because it's going to form the jejunum and the ileum and the cecum, ascending colon, most of the transverse colon. So that means it becomes a very, very long portion of the gut tube. In order for that part of the gut tube to get long enough to become all of those things, it has to start getting longer by around the 6th week of development. The problem is that at that age, the abdominal cavity is quite small, and most of the space in the cavity is already occupied by the liver and the kidneys, which are quite large. So what happens is that in order to allow the gut tube to start getting longer, it emerges out of the abdomen and migrates out into the umbilical cord. It needs more space so it can get longer, so it has to leave the abdomen and migrate out into the umbilical cord, and it forms this loop of intestine called the intestinal loop. Now, because this is the midgut that's doing that, and because the blood supply to the midgut is the superior mesenteric artery, not a surprise that as the loop of intestine extends out into the umbilical cord, it drags along with it the superior mesenteric artery that sort of sits right down the middle of that loop. And that artery that's running in an antero-posterior direction serves as the axis of rotation. We said it will rotate 270 degrees. Now on this diagram, it is showing about 180 degrees of rotation, so the rotation is not yet complete on this. In order for us to appreciate what happens in this rotation, I'm going to use a prop. So let me say that this piece of cord is that midgut, and it has formed a loop that is extended out into the umbilical cord. And we can call this upper part of the loop the proximal portion of the loop. So that's what's going to form the more proximal part of the midgut, primarily jejunum. We'll call this inferior limb of the loop the more distal part of the loop. So that'll form the more distal part of the midgut, let us say the ileum and the cecum. So we're saying that when it extends out into the umbilical cord, it has the artery running right down the center of the loop where my thumb is sitting here, supplying the gut tube. And that artery running down the middle of the loop is serving as the axis of rotation. So while this intestinal loop is out in the umbilical cord, it's going to rotate 270 degrees around that around that axis of the superior mesenteric artery. And that rotation will be counterclockwise as viewed from the ventral side. So it goes from this position, 90 degrees brings it to this, 180 brings it to this, and 270 brings it to that. Now, let's look at that again, but this time only paying attention to the more proximal part of the intestine, the upper part of the loop. That becomes jejunum. What we're saying is 90 degrees of rotation brings that to the right, 180 degrees brings it to the left, and 180 degrees brings it to the bottom, and 270 degrees brings it to the left. So a little later in development, by the 11th or 12th week of development, when this intestinal loop retracts out of the umbilical cord and goes back into the abdomen, the jejunum is now on the left. And indeed, that's where it is in the adult. So it got from here to here by that 270 degree rotation. If we look at this again, but this time focus our attention on the lower part of the loop, the part that's going to become the ileum and the cecum, we can see that it starts off on the bottom. 90 degrees brings it to the left, 180 degrees brings it to the top, and 270 degrees brings it to the right. So when we retract back into the abdomen, the ileum and cecum is on the right. And indeed, the ileum and cecum are in the lower right quadrant. Now, if we do this one more time, but instead of keeping our attention on the loop, if we keep our attention on the more caudal part of the gut tube, that's not part of the loop. As the loop rotates, it drags that part of the gut tube around with it. So that means that 90 degrees of rotation will drag that up the left side of the abdomen, 180 degrees drags it across the top of the abdomen, and 270 degrees drags it down the right side of the abdomen. So by dragging it up the left, across the top, and down the right, we've now created the inverted U of the colon. So this would be the descending, this would be the transverse, and this would be the ascending colon, which brings us back to the cecum. So the adult positions of the jejunum, ileum, cecum, ascending, transverse, and descending colons are all determined by the 270 degree rotation of the midgut. But notice that that has no impact upon the structure, the adult position of structures relating to the foregut, like the liver and the spleen, which is in the dorsal mesentery of the stomach, because that's going to be affected by the foregut rotation. So it's two separate rotations having two separate impacts upon two separate portions of the gut tube. Now, another very important issue relating to this development of this intestinal loop, we said that it extends out into the umbilical cord at about the 6th week of development. and it remains out in the umbilical cord through about the 11th or 12th week of development, and it's sitting out there waiting for the abdomen to get large enough so it can retract back into the abdomen. And we've just said that while it's out there and in the process of retracting, it goes through this rotation. But there's a very important developmental abnormality that results from a failure of that intestinal loop to retract out of the umbilical cord. If it remains out in the umbilical cord and the baby is born with some portions of the intestinal loop out in the umbilical cord, that's called omphalocele, in which you'll find elements of the GI tract not inside the abdomen of this newborn, but rather out in the umbilical cord. There'll be this defect in the ventral wall, which is the remnants of the umbilical stalk, containing loops of bowel. So omphalocele is a developmental defect resulting from a failure of the intestinal loop to retract from the umbilical cord. And of course, in omphalocele, those loops of intestine will be found inside the umbilical cord, meaning that it's covered by the amnion, which means that it's not in contact with amniotic fluid. And I make that point in order to contrast it with a defect that we talked about earlier when we talked about the lateral body folding that occurred at 4 weeks of development. When the ventral body wall, right and left folds, are supposed to fuse together, and we said that if there's a failure in that fusion, we'll have something called gastroschisis or gastroschisis, in which there will be abdominal content outside of the abdomen free in the amniotic cavity. So gastroschisis or gastroschisis is a defect not really of the GI tract, it's really a defect of the abdominal wall in which GI tract organs end up outside of the abdomen. And an important distinction here is that in omphalocele, which is the defect of failure to retract from the umbilical cord, the organs are within the umbilical cord, covered by amniotic membrane, therefore not in contact with amniotic fluid, whereas in gastroschisis, the organs are in the amniotic cavity and are in contact with amniotic fluid. This diagram shows you a structure that can result in another defect, and that relates to this little duct right here. What that duct is, it's called the vitelline duct, and what it is the original continuity between the part of the gut tube that ended up internalized in the embryo and the part of the endoderm-lined yolk sac that's left outside of the embryo. And there persists for a short time a communication between the internalized part and the externalized part, and that communication is called the vitelline duct, and that's what's seen here, and it extends out into the umbilical cord. Now, usually that vitelline duct fuses and disappears, leaving us with just the gut tube inside the embryo with no communication to the outside. Sometimes that vitelline duct remains patent. There's an open communication out into the umbilical cord, so that when the umbilical cord is severed after birth, we now have a patent communication between the intestinal lumen and the outside world, and that would be called a vitelline fistula. And so you would, of course, have fecal matter, or earlier on meconium, escaping from the GI tract out at the umbilicus. A variation on that, which is actually quite common and occurs in 2 to 3% of the population, is most of the vitelline duct fuses and disappears, but just this little very proximal part of it, close to the intestine, remains patent. So you end up with a little diverticulum. All of this fuses and disappears. You end up with a little outpocketing from the wall of the ileum, and that's called an ileal diverticulum or Meckel's diverticulum. So Meckel's diverticulum is a defect that usually is asymptomatic, but not always, and that's a result of a remnant of a small portion of the vitelline duct. There are certainly a whole variety of abnormalities resulting in malpositioning of organs, where organs don't end up in the normal or typical location, and that can be as a result of malrotations. We talked about the normal 270-degree rotation of the midgut and the normal 90-degree rotation of the foregut. But if those rotations either don't occur completely, or occur in the wrong directions, you'll have organs ending up in places that are atypical. We already talked about an error in the rotation of the ventral pancreas that can result in annular pancreas. And the last major congenital defect that I want to mention is defects that result in stenosis or atresia of some portion of the GI tract, where some portion of the lumen of the GI tract is either narrower than it should be or completely obliterated. And the way those typically occur is that during development, after the gut tube is formed, there's a tremendous growth of the epithelium lining the gut tube, lining the lumen, and that epithelial development results in a plug. The lumen becomes occluded by that epithelium. It's called an epithelial plug, and then subsequently it luminizes again. After the epithelium proliferates and creates this epithelial plug, that epithelial plug recanalizes as a result of death of epithelial cells, recreating the lumen. So if there is a segment of the gut in which the recanalization doesn't occur, you're going to have atresia in that segment of the bowel. So atresia of a segment of the gut tube is a result of a failure to recanalize the epithelial plug, and stenosis can be a similar kind of a defect in which you have insufficient recanalization so that the lumen is smaller than it should be. So those are the major developmental events that lead not only to the normal adult anatomy, but to the abnormal anatomy seen in congenital defects. And now we'll turn our attention to a discussion of a variety of other adult anatomical features relating to blood supply and venous drainage of the gut tube.